Delegate Rosenberg said we can't. Good afternoon, everyone, and thank you for coming back to be with us. It is 3:01, and we are going to start our bill hearings. And if you notice, for our amazing committee members, today we have 4 bill hearings, but there'll be days where we'll have 13, 14. So the days are gonna get longer for us. So as you plan ahead and plan your schedule, I really appreciate you being here. This is the priority, and I thank you for all of you for coming on time. You're doing a great job as well. So it is a little bit hot in here today, and I apologize if you could see my face. It matches my jacket. And it's just that it's very hot. We did report it, so be patient with us. We have the windows open in the back. So maybe that will make us speak quickly and get it over with, no? Just kidding. So anyway, we'll get started. Good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. I am your chairman, Jocelyn Peña-Melnick, and I have my amazing vice chair, Ariana Kelly. This is our first session back in person since 2020, so I ask for your patience if we encounter any technical or streaming issues. And again, if we encounter like a really hot committee, which we have today, as a reminder, all witness testimony must be uploaded from 8 a.m. to 3 p.m. 2 business days before the hearing. And I can emphasize how important this is, because if you do not turn it in on time, then it stops everything for staff, right, to complete the process, and it makes them work a little harder. So please ensure members and witnesses are familiar with our witness guidelines, which are posted on the committee page on the MGA website. Please set your electronic devices to vibrate and don't hold conversations in the committee room while testimony is happening. We're going to hear from the bill sponsor and the sponsors panel. The bill sponsor testimony is not limited, but please don't take 10 minutes. While all witnesses will have 2 minutes to provide testimony. A timer is displayed. You see it says blue sky timer right there, and you will have 2 minutes to provide the testimony. A sound will be played once your time has expired. Please adhere to our usual committee rules of 1 question and 1 answer from the panel. Now, 1 question and 1 answer from each witness. Please keep your questions brief, okay? We don't want to hear a story, just a question. And for the committee members and the audience, I try really hard to adhere to the rules. Sometimes I may be flexible, sometimes depending on the time, you don't see me keeping it, then I won't allow, another question or just the panelists, whoever we direct the question to, please identify them, because if we allow everyone to answer, then we're here all day. And I want to really be respectful of your time. It's 3:05. We say we will start at 3 o'clock because I want you to be able to go home at a decent time, okay? Members of the public will be able to view the live stream of this hearing on the Maryland General Assembly website and on YouTube. Today we will hear the bills in the following order. First, we'll start with House Bill 271, House Bill 111, followed by House Bill 121, and then House Bill 48, which will be the last bill. If you're wondering, how do I make the decision? Just in the interest of being transparent with all of you, I look at as simple as how many witnesses does a bill have? And if a bill only has 2 witnesses, why should they be the last one when there's one with 20 ahead of time? I do try to be accommodating. If you have another bill hearing in another committee, I can put you last or whatever order you think. I can do that. We're flexible here. But if you're wondering how we make the decision, that is how we're making it. So first, we'll start with House Bill 271. That's Delegate Kelly and Bagnall, the 988 Trust Fund funding. And will you be so kind, Delegate Kelly, and come out with your panel?
Pull the chair around, maybe. For the purposes of efficiency, I'll get started while we make sure we have enough chairs. I think we need one more chair. So,
Two more chairs.
more
We
chairs?
can swap out.
or we can swap out. Usually there's more chairs here, but
You can-
welcome.
Excuse me, you can actually pull two
We'll pull
chairs
these
up.
two.
Feel free to do that. Good afternoon, everyone.
Good afternoon. Thank you, Madam Chairman and members of the committee. I am here today with House Bill 271. For those of you who are returning members of the committee, you will recognize this as a continuation of the work of Delegate Lewis Young, who is a traitor who left us for the Senate.
And do I know another traitor? Is there, wait a minute. Is there, 1 second, please. You open yourself up to that. Is there another traitor in here? No, just kidding. Go
That
ahead.
being said, it is a really important piece of work, so I've picked it up from her, and I believe Delegate Bagnall will be carrying this across the finish line. But it is a cross-file of a bill from Senator Augustine, which you may have heard of because it has already passed the Senate unanimously. You may have seen it in the news because it was the first bill that the Senate chose to pass this year. What does the bill do? House Bill 271 invests $12 million in the FY 2025 budget into the 988 Trust Fund. The experts here with me today are going to talk to you really specifically about why that is critically important. I am just here to tell you the basics. The 988 Trust Fund is a non-lapsing fund that supports the 988 Suicide and Crisis Lifeline. The trust fund also provides the resources to develop and implement the delivery of behavioral health crisis response services statewide. You're going to hear from a couple of proponents today, but please do check your file because there is so much written support for this legislation that I want to make sure you guys read, in addition to having the benefit of hearing from the witnesses today. Prior to the implementation of the 988 Lifeline, behavioral health crisis response resulted more times than not in a call to 911 or a visit to a hospital emergency room. Options which tend to be less effective for mental health crises and also divert critical resources and care away from other emergencies. The 988 Lifeline offers free 24/7 supportive counseling and connections to trained resources that can safely de-escalate and resolve crises. It provides vital assistance to those experiencing behavioral health crises immediately, rather than waiting days or weeks to get an in-person appointment. Additionally, 988 trained staff connect individuals with community resources that help maintain stability after the immediate crisis has been addressed. It's being used by more and more people every day, and it is effective. According to Hopkins, approximately 60% of people brought to the ER with a behavioral health crisis issue are discharged because their crisis does not qualify as needing inpatient care, but they're still in need of assistance. The 988 Lifeline addresses this gap in care, providing resolution over the phone to 80% of the calls received. 80%. So this $12 million appropriation in this bill will expand the Lifeline's capacity to serve Marylanders experiencing mental health challenges and bolster the system long term. It's a lot of money, but it is money very, very well spent. So with that, and I will remind you that the Senate already passed this unanimously. So I'm going to urge a favorable report and remind you all to look in your file because there's so much written support for this as well. And I will pass the microphone over to the experts who can tell you why this is a really smart use of state funding.
Good afternoon, members of the committee, Madam Chair. For the record, my name is Dan Rabbit. I'm a policy director at Behavioral Health System Baltimore. BHSB is an independent nonprofit that serves as the local behavioral health authority for Baltimore City. And we're happy to support HB 271. You have my written testimony, so I won't go into great detail about how 988 works, but I'm going to focus on how we arrived at the $12 million figure. That figure comes from a SAMHSA-funded analysis of what the state of Maryland needs to have the capacity necessary to provide timely responses to the calls that are anticipated to come into 988. That analysis estimated Maryland would need between $10 and $17 million in order to have the capacity it needs to answer calls in a timely fashion. And what we've seen so far is that the increase in calls are pretty much in line with what was anticipated in that analysis. We've seen a 50% increase in calls statewide to 988 and a 4-fold increase in texts and chat over the same period of time. And that's usually young people who are seeking help when they are in distress. So we think that the $12 million is in line with that $10 to $17 million estimate. And there's reasons that it might even be a low estimate. The analysis was done in February of 2021 when we did not know what inflation would be like. We did not know how salaries would spike, especially in the mental health field where there is a workforce shortage. We also know that text and chat is really important, and only 3 Maryland providers are able to provide text and chat capability out of the 8 that we have in the state. So that's an area of growth. And Maryland has always been a leader with these services, but in the last year, as more and more states are looking at 988 as a really important resource, Maryland has fallen more into the middle of the pack in terms of how quickly we're able to respond to calls. And we want Maryland to be a leader. We want to be answering 90% or more of the calls that come in from Marylanders by Maryland call centers. And we're not there right now. So for those reasons, we think the $12 million is a reasonable investment, and we urge a favorable report.
Thank you. Who is next?
Good afternoon, Madam Chair and committee members. My name is Quinita Garrett, and I'm the Director of Call Center and System Coordination with Baltimore Crisis Response. We are one of many 988 call centers that staff the line in Maryland. 988, it provides a wide range of supports for individuals experiencing a behavioral health crisis, people who are, as well as people who are concerned about those individuals. 988, it often acts as a bridge for many people who need support, such as supportive counseling, crisis intervention, and suicide intervention. We receive calls to help people dealing with various life situations where they have exceeded their ability to cope. Counselors work to provide callers with support and aim to help connect them with the needed services and resources. BCRI, along with many other 988 call centers, have used funding to recruit staff, add additional trainings, provide competitive wages, and invest in technology to assist with quality assurance and care. Funding is vital to continue to enhance and improve upon training needs and to ensure adequate staffing to decrease wait times. Many centers have used funding to develop follow-up programs and to ensure that counselors are provided with the appropriate and needed supervision. Funding is used to support counselors as well and to educate them on the importance of their own self-care. Maryland 988 centers are also invested in robust workforce management software and updated technology. 988 has provided many Marylanders and citizens across the country with support. Most of the calls are resolved on the call center level with just supportive counseling and providing resources. There are many important components to 988, and counselors are often the first point of contact for grieving spouses, individuals diagnosed with cancer or other illnesses, a young adult experiencing suicidal thoughts for the first time, and many other stressful and emotional situations. I ask that you vote in favor of House Bill 271. Thank you.
Thank you for being with us. Next.
Todd's next. And you can move the microphone over. That's easiest.
Good afternoon to the committee, and good afternoon to the chair, who I've worked with for many years.
Good afternoon.
My name is Todd Ledbetter. I'm a Maryland resident, taxpayer, homeowner, and volunteer with NAMI Prince George's. In 2005, I was diagnosed with bipolar depression. My depressive bouts had a devastating impact on my career, my finances, my self-esteem, and my family. The treatments I tried were ineffective, and after battling depressive episodes for years, in January 2020, I woke up one night and decided I'd had enough. I got dressed and started walking toward railroad tracks about a mile from my house, with the thought of lying down in front of an oncoming train. As I walked, what I believed to be a divine thought came in my mind. No matter what happens, you have to keep your son's father alive. I pulled out my phone and Googled the number for the National Suicide Prevention Lifeline, which at the time was 1-800-273-TALK. Today, those seeking help in crisis have the benefit of 988, which makes life-saving resources even more accessible. As awareness of the importance of emotional wellness grows, as a state, a nation, and a human family. We must redouble our efforts to ensure that behavioral health resources are adequately funded, because whether you have a diagnosis, know someone who's struggling, or you're just trying to live your best life, emotional wellness, like physical wellness, is everyone's issue. The proposed increase in funding for the 988 line is just a small step in addressing a need that impacts us all. By the way, I was eventually able to connect with effective resources, and today I'm living depression-free. I'm a witness that with the right support, healing is possible. I thank the committee in advance for a favorable report for HB 271. Thank you.
And thank you for sharing your story, Todd. I know your family for many years, and you know, I know it takes a lot to share, and we really appreciate it, and I want you to know that it matters, okay? And give my love to your beautiful family and your
Absolutely. Thank
boys. Who will be next?
Good afternoon, everyone. My name is Deepika Chung. I'm honored to be here today to testify on behalf of Every Mind in support of HB 271. I oversee operations for our 24/7 988 hotline. Every Mind has supported our community's mental wellness for over 65 years. Since 2005, we have been one of the centers that answers the National Suicide Prevention Lifeline, providing phones, chat, and text services. Compared to the same time last year, the demand for Every Mind's hotline services has increased 44% on calls, 500% on texts, and 200% for chats. In the first 6 months since the 988 launch, we received close to 14,000 contacts from the public. Much of that demand is driven by young people under the age of 24. During this period of tremendous increase in demand, this funding has allowed us to provide better support for our counselors and higher quality service for the public. No matter how long a counselor has been on the hotline, every contact is uniquely challenging. With funding from the 988 Trust Fund, we've been able to build our counselors' knowledge and skill set through additional continued education, improve our technology, and increase supervision and support on the front lines. 988 counselors are part of Maryland's team of mental health first responders in our fight against the profound mental health crisis our communities are facing. With these funds, we are adding a robust full-time counselor team to our volunteer and part-time workforce. To reduce counselor burnout and increase retention, we have also significantly expanded our coaching and team building practices. A full-time workforce makes coverage for our services on the hotline more stable and more professional. Since 988 launched in July, 95% of our calls and chats resulted in the escalation of crisis without any further need for any emergency service intervention. Our support is not only vital, it saves money for the county, the states, and our constituents. Our services keep families, friends, and neighbors out of the hospital, the jail, and sometimes even the morgues. We are a first line of defense, and we do it well. Your support for this funding saves lives every day. Thank you.
Thank you for being with us. I'm going to now open it up for questions for this panel. Delegate Rosenberg, followed by Delegate Hill.
There's a significant cost, but it's put off until FY25, so it's in the budget that we will be considering next year, not this year. Is that correct?
Yes.
And have there, if I may, have there been any conversations about a potential source, or is that a discussion for after the bill signing?
That we have not had any discussion about that yet.
Delegate Hill.
Thank you, Madam Chair, and thank you all. Thank you to the sponsor, and thank you to all who are here. You, remind me of your name,
Dan?
please.
Dan Rabbit?
Thank you, Mr. Rabbit. You talked about a 80% resolution, and I'm just curious, it's two parts. How do you track that to know that 80% of the folks got an adequate response to their call?
That statistic comes from Vibrant, which is the nonprofit that administers the lifeline for SAMHSA. So They track calls and track what calls require additional first responders to go out. But maybe I'll pass it to Juanita or Deepika to talk about what a adequate resolution looks like.
Say someone who comes in after an attempt and we get a history, which is medical information, where they say, I made the phone call and this didn't happen. And the reason I'm asking, I think it's an important program. I'm happy at the first year's response and the funding, but we have so many downstream problems where we can't get people connected with the right resources. So I'm just curious about if we know we have limited resources to connect people with, how are we having 80% success in getting people a satisfactory solution?
So I can say that with our call center, that more than half of our calls, or the callers that call in, are already connected to some type of support. They're calling for supportive and emotional support. Supportive counseling and emotional support. So they're just calling because they received bad news, or they need a way to cope through something. They know they have anxiety, but they can't process their coping skills at the time, so they need assistance. Or individuals who are chronically suicidal and just need someone to talk them through that at the moment. We do a ton of follow-up in the call center, so we do find out the outcomes often with the follow-up calls. People will say, I received help, I saw my therapist, we appreciated it, and it doesn't just stop at one follow-up. We do a ton of follow-up.
Thank you. We have Delegate Chisholm.
Thank you, Madam Chair. I just want to address one of the unfavorables in here and see if any of you can speak to it. And it says, currently people call 988 expecting confidentiality and privacy. Some callers are surprised when cops break down the door, handcuff them, and haul them off to involuntary psychiatric hospitalizations. Do we have any instance of this ever happening?
So it can be really tough with a counselor on the phone and you have a caller who may say, I'm suicidal, I have a gun in my lap, and I'm going to kill myself, but I don't want you to send anyone out. Some callers may not engage in the safety plan. They may say, I'm going to do this, and we will contact police and request a wellness check. So that can happen even if someone says, I'm going to kill myself, but I don't want you to send anyone out. The counselors have a responsibility to protect them, and they will send police out to do a wellness check.
My pleasure. Any other questions? Seeing none, thank you so much for your testimony today, and thank you for the work you do. It's really tough work. Thank you.
Thank you, Madam Chair.
Thank you. My pleasure. Next, we have Mr. Dan Martin, followed by Josh Howe. Actually, if you could both come up because it's favorable testimony. Who would like to get started?
I can go first, Madam Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland, here in support of House Bill 271. The establishment of a comprehensive behavioral health crisis response system has been a priority for MHAMD and the Maryland Behavioral Health Coalition for 2 decades now, ever since Delegate Rosenberg passed legislation back in 2002 enshrining the crisis response system in statute, with the goal of creating a 24/7 system in jurisdictions across the state that can serve people in a behavioral health crisis. And I'm happy to say that we are closer to that goal than we've ever been before, thanks to the really hard work for over the past few years of a range of stakeholders, consumer and family advocates, our state partners, crisis providers. We have made enormous progress in that goal, in that vision that we had. And 988 is a central component to that build-out. It's the main access point to our behavioral health crisis response system. And as demand for behavioral health services has grown and awareness of 988 has grown, so too have call volumes to the 988 call centers, and this requires additional investment to ensure that these responders have the resources to help our friends and families in need. And for those reasons, I ask your favorable report on House Bill 271.
Thank you. Next, please.
Good afternoon, Madam Chair and members of the committee. My name is Josh Howe. I work with Compass Government Relations here on behalf of NAMI Maryland, or the National Alliance on Mental Illness. Here just adding our voice to the overwhelming chorus of support for this legislation for all the reasons that you have already heard, and to reasons that I will point to you in my written testimony. NAMI Maryland is supportive of this bill as well.
Thank you for your advocacy. Are there any questions for these two witnesses? Seeing none, thank you for being with us. And for the committee, this will conclude the bill hearing on House Bill 271. But if you notice, there are a lot of written testimony as well. And just for the people here today and for the people at home, written testimony is as important as the personal testimony, and we do read it and consider it. Thank you so much. Next, we have House Bill 111. Delegate Charkoudian, Maryland Medical Assistant Program, Maryland Children's Health Program, and Social Services Program, eligibility and enrollment. Will you be so kind and come up with your panel, please? And you can bring some chairs up as well. Good afternoon, how are you? It'll go up. It'll go on. Thank you.
Thank you. Okay, here we go. Thank you. Chair Pena-Melnick, Vice Chair Kelly, it's exciting to say those words, so I'm just going to say them, even though she's not here right now.
Thank you.
And members of the HGO. For the record, Delegate Lori Charkoudian here asking for a favorable report on House Bill 111. What House Bill 111 essentially does is it streamlines enrollment and the application process for a set of safety net services that we want everyone who is eligible to get, and yet our systems have set up barriers through no fault of any individual. Our systems have set up barriers that make it difficult to access these services. And so we essentially have a situation where the same people need and should have access to SNAP as need and should have access to Medicaid and need and should have access to home energy programs, electricity and utility assistance. But we have 3 different agencies and 3 different application processes to access these services. And the thing about economic struggle is it doesn't stay in its lane, right? And so we have our agencies that seem to, one place is where we deal with health, and one place where we deal with hunger, and one place where we deal with energy assistance. But the folks who need those services need all of those services. And so we have a process that is both inefficient for the individuals who may be struggling, who may be working multiple jobs, who may have children, who may be taking care of family members who are sick, and that they have to upload similar documents, fill out the same forms, establish the same eligibility, and they have to do that every year. And so people lose access to these critical services at times when they are still eligible, but there's a process problem that keeps them from having access. And so what this bill does is it uses express lane eligibility for the Medicaid piece and categorical eligibility for the energy assistance piece. And once people sign up for SNAP, essentially, which has the highest enrollment out of these 3, they will become automatically enrolled in Medicaid. They become automatically enrolled in the utility assistance. There's some details of how we do that, and I'm happy to answer technical questions if folks want them. But I just want to highlight that this is going to increase the number of people who are insured, which has a broader benefit to all of us, to everybody in the community, both the individuals who get insurance as well as broader public health, and then, of course, lower costs for our emergency room and uninsured costs. And also, it'll keep people from having their energy shut off. But also, it becomes much more efficient for the state. And so we can take money that is currently being spent with 3 sets of people doing the same thing across 3 agencies, and instead invest that money in the services or in outreach to support people to fill out the forms, or in any number of places where that money could be used more efficiently. And so we have more efficiency for families who need the services, more access to the services, and greater efficiency for the state. And with that, I'll turn it to my panel to talk about more details.
Who's next?
Okay, thank you. I'm Vinny DeMarco, President of the Maryland Healthcare for All Coalition. Thank you, Madam Chair, Madam Vice Chair, for this opportunity. This committee has led the nation in expanding healthcare coverage. Maryland has reduced our uninsured rate dramatically. There are still, however, 6% of our population who are uninsured. We believe there's a 3-part way to go from 6% to 0%, and a key part is automatic enrollment for people now eligible for free health care but not enrolled. You made a big step in that direction in 2019 with the Easy Enrollment Program, which is being replicated across the country, and Senator Chris Van Hollen has introduced a national bill. and Delegate Charkoudian's bill a couple years ago to enroll people when they file for unemployment insurance was another big step in that direction in finding people who are eligible but not enrolled and getting them enrolled. Those two programs brought thousands of people into the rolls who weren't there before, especially for Medicaid. We know that there are approximately 60,000 Marylanders who are on the SNAP program, eligible for Medicaid, but not enrolled. Under this provision, this legislation, we would get them enrolled. And as Delegate Charkoudian said, it would help them and help all of us. There's a hidden healthcare tax. When someone goes to the emergency room, runs up a huge bill, can't pay for it, is uninsured, it affects and increases our premiums. For the uninsured and for all of us, it makes sense to do everything we can to go from 6% uninsured to 0% uninsured, and this legislation is a big step in that direction. Thank you, Delegate Charkoudian. And Madam Chair, thank you for your leadership on easy enrollment. It was your bill, and we are telling all the country how great it is. Thank you very much.
Thank you for your leadership. Who's next? In this committee, actually, when we put in a bill, it's everyone's bill, because all of us vote on it, we discuss it. I heard that Delegate Chisholm did a great job this morning in public health on one of our bills, so it's the committee's bill. Who's next?
Good afternoon. Thank you, Madam Chair and members of the committee. My name is Laura Hale. I'm the Director of Government Relations with the American Heart Association. We offer our strong support for this bill for all the reasons that have already been outlined, but we know that good heart health starts with good health insurance, with good food at the end of the day, and making sure that we have the things that have overall health, like making sure that our lights stay on and our energy bills get paid. And so for this reasons and so many, we see that this is really a way for the heart health of Marylanders and for long-term health when we can pass this bill and really help all of our Marylanders to stay healthy. So thank you so much.
Thank you for being with us. Who's next?
Great. Thank you, Madam Chair, Madam Vice Chair, members of the committee. My name is Jake Whitaker. I'm Director of Government Affairs at the Maryland Hospital Association, here to testify in support of House Bill 111. We believe that widely accessible health coverage is critical to hospitals providing Marylanders with the best care possible. By granting automatic Medicaid eligibility to SNAP enrollees, individuals who may not have had access to health coverage can get access to excellent health care. House Bill 111 also supports the goals of Maryland's unique total cost of care model. Under this model, Maryland hospitals strive for and held accountable for lower costs and improved population health. This bill would not only increase access to health coverage for Marylanders, but would also address social determinants of health that have an impact on overall population health. As a result, this bill would help hospitals meet the goals of Maryland's total cost of care model and provide Marylanders with the best care possible. So for the aforementioned reasons, we respectfully request a favorable report for House Bill 111.
Thank you. Who's next?
Good afternoon, Chair Pena-Malik, Vice Chair Kelly, and members of the Health and Government Operations Committee. My name is J.D. Robinson, and I am the Program Associate for SNAP at Maryland Hunger Solutions. For over 10 years, we have assisted anyone in Maryland seeking food assistance through applying for SNAP and connecting them to local resources such as food pantries. And for the last 3 years, most of this has been done through a toll-free hotline where we field anywhere between 400 and 500 callers in any given month, with nearly a quarter to a half of them asking for additional assistance in healthcare and energy. Applying for these benefit programs is not an easy task. We equate applying for SNAP with doing your taxes. It's time-consuming, headache-inducing, and often requires a navigator in the field. To continue to ask low-income individuals to repeat this process multiple times over multiple programs only increases their frustration and potentially their distrust. Ensuring automatic enrollment across these programs through this legislation can greatly alleviate the burden these families face and reduce administrative time and effort for the caseworkers that are reviewing them. Each of these benefits will be critical as households continue to navigate the loss of multiple pandemic-related programs, including the nearly $70 million a month in SNAP benefits that the state is losing beginning this March. 360,000 SNAP households will be seeing a decrease in their monthly benefit, with some households potentially losing hundreds of dollars in their monthly SNAP benefits. Many of these families are likely to turn to programs for additional support, and allowing them to do so easily, effectively, and automatically will advance health equity and the well-being of our most vulnerable Marylanders. Thank you for your consideration. We urge a favorable report on House Bill 111.
Thank you. Who's next?
Hi, Chairwoman and members of the committee. My name is Julia Lemp. I'm the Advocacy and Public Policy Specialist with Capital Area Food Bank. And on behalf of the Food Bank, we offer our support for House Bill 111 to require the Maryland Department of Health to establish express lane eligibility for Medicaid and SNAP and encourage categorical eligibility for energy assistance and SNAP. The Capital Area Food Bank serves over 200,000 food insecure residents in the two largest counties in Maryland, Prince George's and Montgomery. Last year, we distributed over 23 million meals to Maryland clients through a network of 138 nonprofit partner organizations and many direct distribution sites. However, we strongly believe that food alone will not address food insecurity, and we're thoughtfully engaging in innovative means to address the root causes of hunger. House Bill 111 addresses a critical intersection between hunger and health. Our clients, many of whom utilize SNAP to help feed their families, are also facing health disparities and inequities. Individuals in food insecure households have a much higher rate of developing heart disease, diabetes, obesity, and higher BMIs than their food secure counterparts. In fact, they're 18% more likely to develop ongoing chronic health conditions according to the USDA. These health challenges carry significant economic costs to an individual due to increased healthcare spending and lost earnings. And additionally, low-income individuals may be working jobs that don't offer healthcare. They may be facing preventative costs to obtaining healthcare for themselves and their families. And as mentioned before, these processes are not easy. Removing barriers to healthcare access for low-income families will put our state one step closer to achieving health equity for all Marylanders. So we strongly encourage a favorable report on this bill and appreciate your consideration. Thank you.
That's all of us, I think,
That's all?
right? Yes,
Okay,
that's everyone.
wonderful. Want to make sure there was no one behind you that was going to come before we open it up to questions. So Delegate Charkoudian, have you seen the letter from the Maryland Department of Human Services and the letter from the Maryland Department of Health?
Yeah, so we already have, thank you for the question. We have an amendment that we drafted with the Department of Health to just change the language to separate out the express lane eligibility for renewals from the express lane eligibility for new enrollees. So I've got the language for that. It just came in the last hour or so, so we'll get it to whatever subcommittee.
So for the committee, the Department of Health on page 2, they're actually supporting favorable with amendment. And the Maryland Department of Human Services, favorable with amendment, have you seen their amendment?
Yeah, it's it adds one word, I believe. I'm not finding it right this second, but yes, and it's
Household with N.
That's correct. Yeah, it's perfectly fine.
Okay, wonderful. Now I'm going to open it up for questions. We first have Delegate Hill.
Madam Chair, and thank you, Delegate. This is either for you or Mr. DeMarco. If this goes through and everybody eligible applies, what will we reduce our number of uncovered Marylanders? How far will we reduce that number to? Because having a great healthcare system is no use if you can't access it, right? So we have how many now, and if this goes through and everybody eligible does it, how small will our uninsured population go down to?
Go ahead, yeah.
Yeah, it's a great question.
Don't touch it, they'll do it for
I
you.
won't touch anything. Delegate, we don't know the exact numbers. But there are estimates anywhere from 250,000 to 300,000 people who are still uninsured. Even though we've gone from 13% to 6% insured, covered 400,000, there are still that many uninsured. You could think about that group in 3 categories. There are people who are eligible for free health care but don't know about it. There are people who need additional subsidies, and people who have immigration barriers. Those are the 3 categories of people, I think, in that group. We don't know exact numbers, but we think maybe a third, maybe up to 100,000 of the people in the first category are people who are today uninsured but eligible for free health care. And we believe, based on estimates, that 60,000 of those folks are on SNAP. And that if we did this bill, we would make a big dent. There's more work to do, but it would be a big dent in the number of uninsured.
Any other questions for this panel? You have to put your light on. Delegate Taveras.
Thank you. No, this is a great bill, obviously, very supportive. I don't know if you had a chance to look at the report that came out on hunger poverty from, I believe, the Capital Area Food Bank and the people who are just food insecure in the region, particularly post-COVID. Is there like a percentage of individuals you think that would be able to be captured under this bill that would fit within the numbers of that study? If somebody could look into that, that would be really, I think, helpful to kind of gauge how much of an impact this would have locally.
Thank you. I'm not sure I'm familiar, I don't know if I know the exact study. I've read several studies about the increase in food insecurity during COVID, and then I think too many folks thought that then we finished COVID, which we haven't, and we finished food insecurity. The numbers have really stuck, and there's a higher percentage now, of course, who are food insecure and economically insecure, and sort of we're so close to the edge before. So if there's a specific number you want us to try to connect, or if Julia wants to connect with this bill, but I do see this bill addressing sort of that set of folks. And frankly, this bill for me came from, if you'll indulge me for a second, Madam Chair, my work directly with constituents during the pandemic who had been close to the edge but had never needed assistance before, suddenly needed assistance. And my office was scrambling with state agencies trying to get people enrolled. I'm sure you were too. Lots of people here were. And that was when I realized it was the exact same set of applications 3 times over. So that sort of was the connection for me that led to this. But we can see if we can kind of make connections around specific numbers for you as well. Thank you.
Thank you. See no other questions. Thank you so much.
Thank you very much.
Just
I
wait.
think I'm the next bill as
You
well,
too.
so I'll just stay here.
Actually, you can stay there because we have some more witnesses.
Oh, on this bill. Oh, I'm
On
sorry.
this
Then
bill.
I'll move.
Yeah, that'll be great. We have Lead Hudson, and we also have Steve Rabe. Will you be so kind and come up? And you have 2 minutes each. Good afternoon. How are you today?
Good afternoon, Madam Chair. I am Lee Hudson. I'm here on behalf of the Evangelical Lutheran Church in America. We're a faith community in our state, scattered from Red House to Ocean City, and we advocate both for access to adequate health care and sufficient livelihood for all. My testimony is pretty simple. We know who the eligible are. So by creating a categorical eligibility, the services can find the eligible rather than the other way around. And so we urge your support for this bill.
Thank you. Next, please. Good afternoon.
Good afternoon, Chair Pena-Melnick and members of the committee. Thanks for this opportunity to testify on House Bill 111. My name is Steve Robbie. I'm a resident of Annapolis and president of OpinionWorks, a public opinion research firm. I would like to speak to the provision in this bill that would automatically establish a program to enroll people in Medicaid and the Maryland Children's Health Program based on SNAP eligibility. I would like to share observations from past focus group work that we undertook for the Maryland Citizens Health Initiative to understand remaining barriers to coverage facing people who qualify for free or low-cost health care but who do not apply. I would like to speak to the mindset and the barriers that we heard. Observations made by uninsured Marylanders in that inquiry, I would suggest, may also be relevant here to HB 111. Participants in that study were clear they would be more likely to have health coverage if barriers to entry were removed. For example, in that project, we tested the possibility, which Vinnie mentioned earlier, of signing up for health insurance at the same time and place people apply for unemployment benefits, and participants were excited about that idea. Let me give you just 2 of the most important barriers that uninsured Marylanders cited. Number 1, fear of an onerous application process. People admitted that their perception of a difficult process keeps them from even getting started. One person said, "I am definitely one of those people when something seems like it is taking a little bit too long or I hit a speed bump, sometimes I get a little discouraged and I might just go in a totally different direction." Barrier 2, just don't know the process or don't know that they're eligible. One said, "I don't know if you need to apply or what are the requirements to apply. I wanted to apply and I should have done research to find out more about it. I really don't know that part." Based on this research, I can say confidently that this bill effectively removes key barriers to health coverage for uninsured Marylanders and will result in broader coverage. Thank you.
Thank you for your testimony and for being perfect on the timing. Are there any questions for this witness? Seeing none, thank you for both of you. None? Thank you for being with us today. We do have an unfavorable testimony, and that is Ms. Deborah Brocado. Good afternoon. How are you?
Good afternoon. How are you?
I'm doing well. Thank you for asking.
Good. Thank you for having me here today, all the members. So I'm Deborah Brocado here for Maryland Right to Life, and on behalf of our 200,000 followers across the state, we do respectfully object to HB 111. This bill greatly expands Maryland medical assistance and the Maryland Health Children's Program through the SNAP program. And we oppose expanding eligibility, whether it's 60,000, 100,000, 250,000, or 300,000, as the prior panel said, without excluding abortion funding. The Maryland Medical Assistance Program and the Maryland's Children's Health Program are the two primary programs used for publicly funded reimbursements to abortion providers in Maryland. The Maryland Department of Legislative Services, in their analysis of the FY 2022 Maryland executive budget, shows that Maryland taxpayers are forced to fund elective abortions. In the years 2018, 2019, and 2020, over $6 million was spent on almost 10,000 abortions, and less than 10 of those were due to rape, incest, or to save the life of the mother. Maryland is one of only 4 states that forces taxpayer funding of abortion, and that's despite the fact that 60% of Americans do oppose taxpayer funding of abortion. The 2023 Marist poll, with 60% of the respondents identifying as pro-choice, showed that 60% of Americans oppose taxpayer funding of abortion. And in fact, 81% of Americans favor public funds being prioritized for health and family planning services that save the lives of the mothers and their children. Abortion is not health care, and it's never medically necessary. In the Black community in particular, abortion has reached epidemic proportions, and abortion is the leading killer of Black lives. Funding restrictions are constitutional. The Supreme Court of the United States in Dobbs versus Jackson's Women's Health held that there is no right to abortion in the Constitution. They also have stated that the court ruled that the government may distinguish between abortion and other procedures in funding decisions that, so that they may prioritize or favor childbirth over abortion. So I urge you an unfavorable, or at least provide an amendment that excludes abortion funding. Thank you so much.
Are there any questions for this witness? Seeing none, thank you so much for being with us today. We do have another testimony from one more witness that is actually virtual, and it's a favorable testimony from Melanie Townsend Dix. Maybe we just wait a second, and she'll come up. Good afternoon. How are you?
Good afternoon. I'm well. Thank you so much. Chair Pena Melnick and members of the Health and Government Operations Committee, thank you so much for the opportunity to testify in support of Senate Bill 26. I am currently the South Area Director for the Prince George's County Memorial Library System, and I have served on the board of Families USA.
This is actually, if I may, House Bill 111.
Okay, House Bill 111. I'm so sorry.
It's okay.
We also testified on last week.
It's okay. It happens, you know.
Okay, thank you. We did
Our
not
pleasure.
edit that. Thank you so much. But as I stated, my background, I was a former board member of Families USA, which is a national consumer health care advocacy group. I fully support this legislation, which would reduce barriers for Marylanders to get the health care services they need. I personally was enrolled in Medicaid during a difficult time for my family. And I appreciated the people who helped me get connected and enrolled, because I did not know that I was eligible. As a librarian, I have also assisted people who had trouble navigating the healthcare system. We in Maryland need to do everything that we can to make sure the system is as simple as possible, so everyone is able to access the coverage for which they are already eligible. This bill would help break down barriers to access because Marylanders who have already gone through the process of enrolling in SNAP will be automatically enrolled into Medicaid. And by doing so, reducing the unnecessary paperwork for SNAP recipients to remain enrolled in Medicaid. This bill would also help Marylanders get connected with utility services and help seniors enroll in SNAP, making this bill like a one-stop shop for beneficial services to a community in need. Thank you very much for your consideration, and I urge a faithful report for House Bill 101. Thank you.
Thank you. Thank you for testifying on House Bill 111. We really
111.
appreciate it.
Thank you.
It's, you know, we appreciate what you said, and we appreciate the fact that you work at the library. That is very important. Are there any questions for this witness? Seeing none, thank you for your time and your effort. It matters, okay? And
Thank
for
you so
everyone,
much.
our pleasure. For everyone else, this concludes the testimony on House Bill 111. Next, we have House Bill 121. Delegate Charkoudian, you are up again. You're popular here today.
Thank you, yeah. Trying to just hold on to the seat, but.
And can you bring your panel, please?
Come on up.
Thank you.
Yeah, thank you. All right. Thank you, Madam Chair, Madam Vice Chair, committee members. For the record, once again, Delegate Lori Charkoudian, and I'm here requesting a favorable report for House Bill 121. So this bill is about ensuring that once there's this bill is about treatment that people receive when they are involuntarily in a mental health facility. And so could be involuntarily because of an emergency petition because they were deemed to be a danger to themselves or others, or could be involuntarily because they were deemed not criminally responsible, more likely to end up in a state institution. And I think that this committee and this body have done a lot of work and really wrestled with tough issues around this question of the rights of people to be or not to be in those institutions. So there's been a lot of time and effort that's gone around at what point can someone not be held if they don't choose to be held there anymore, and making sure that those rights are in place. And that's very important. But it's my sense, as someone who is a family member of someone who's spent a lot of time involuntarily committed, that we don't spend as much time and effort making sure that the treatment people receive while they are involuntarily committed in either of those situations, either because of an emergency petition or because of being deemed to be not criminally responsible, to make sure that the treatment they receive is actually responding to their needs, is making them well, and is maximizing the likelihood that they will be healthy and well once they return out of the hospital to the community. And so as a result, we do find ourselves in situations where people will be sort of stabilized to a point that they are not deemed to be needing to stay in a hospital anymore because they're not deemed to be a danger to themselves or others, but they come out and they are not on a path to recovery. And I can just say in my own family, this has resulted in a revolving door for someone that I care deeply about. And frankly, it's resulted in a dangerous situation for some of our family members. So that's one piece of it. A second piece of it is that in state facilities, when someone's deemed to be not criminally responsible, they are in our state facilities. And again, there's a need to make sure that they're there not as a punishment, not as a sentence, but they're there to be made well. They're there to be made well enough to be part of society, maybe with the need for additional treatment in the outpatient setting. But that's why we have chosen to house them in a hospital as opposed to in a prison. And yet what we hear about, and what I hear about, and what tragically one of my witnesses is going to tell you about, is that sometimes that happens in those facilities, but sometimes people end up there more warehoused, and in fact, their symptoms can get worse and worse, and their families don't have the ability to effectively advocate for them to actually receive treatment that is appropriate for them and that will help them heal, not just maintain or in some cases get worse. And so what this bill does is it lays out, to some extent it takes information that was in COMAR and adds that to statute, but then it lays out additional rights on the, for the patient in terms of understanding their treatment plan, advocating in their treatment plan, but also for their family members if the patient gives permission. If you think about if you have a parent who has had a heart attack, or if you have a sibling who has had to undergo chemo, or any of those kinds of things, when that person goes to the hospital, you often go with them. Somebody goes with them, and somebody who is not also suffering from the medical condition is there advocating, understanding what's happening, talking to the doctors, making sure that the whole family understands. That's not the case, and that doesn't necessarily happen in the context of mental health. And so when we talk about parity between mental and physical health, there's also this piece that we need of the parity of the ability for family and advocates and the patient to be able to advocate around the treatment. So there's a lot of sort of details about how we do that. There's been some amendments that have been offered, and I'm open to some of them. But that's sort of the big picture of what we're trying to accomplish. And I think as you hear from others on this panel, you'll hear more of the personal stories that make it so important that we move this forward. Thank you, Madam Chair. And if I could turn it over to my panel members, I'd like to do that now.
Absolutely. Who will be first?
Would you like to go next?
Okay, thank you. Good afternoon, everyone. Thank you for the opportunity to speak to you today. My name is Shelley Stokes, and I'm here to testify on behalf of House Bill 121. I've lived in Silver Spring, Montgomery County, Maryland, District 18, for 5 decades. I'm the mother of 3 sons who have also been raised in Montgomery County. I'm very much proud of them. I love them. And this bill would help my youngest son, who is 27. You'll hear more from my oldest son, who is going to testify on Zoom. It isn't easy to come before you to discuss such a sensitive family matter, but I was raised by a family that believes in this country and has served this country, and I believe you can help. I share our story not only because I want you to understand not only can any family be touched by mental health issues, but also any family can encounter complications during the treatment process that can make recovery even more difficult. I tried staying under the radar for a long time. My family member worked diligently and complied with treatment. However, complexities with his case led to new and worse problems. We were in the process of being referred by doctors to NIH and McLean Hospital when an incident occurred that landed my son in a state hospital. Today, a call to 988 instead of 911 probably would have resulted in a different outcome for my son and our family. I say this because a manager in a Staples store called 911 when he thought my son looked like a vagrant. 911 was not caused because of any criminal acts by my son. He was 23, he had no legal record, and no history of violence. Once in the state hospitals, there were more complications. It was difficult to have a seat at or a meaningful voice at the treatment table, although my family member had given his consent and I had power of attorney. So basically, I'm just asking for you to understand that these things happen and to help persons when things go wrong, as you have with 988, as they do when a person's placed in a state institution. Thank you.
Madam Chairman, may I yield some of my time to this witness?
Sure.
Please continue.
Okay, thank you. The only other thing.
That's very kind.
That
Go ahead.
was, thank you, Robin. And actually, she helped me find my voice. She led me to Delegate Charkoudian. I was really afraid to say more, but thank you both very much.
No, you're welcome. This is a safe space.
Thank you. The only other thing I wanted to say is that a patient and family members are central to the development of any treatment plan or goals and should be valued members of the care team. Family members also have collateral information that will provide historical context to aid in treatment and medications. So I found my voice, and I just hope that you all will consider, I've overcome the embarrassment of the trifecta of race and criminal justice and mental health. I've found my voice thanks to people like this, and I'm hoping people like you can open up doors for more progress for a more humane society. Thank you.
We're glad you're here with us. Thank
Thank
you.
you.
Who's next?
You're gonna finish
And Robin,
I'll finish. Yes.
you
Thank
can,
Madam
you can have
Chairwoman.
the full 2 minutes, Robin.
And members, I'm sorry?
You can have the full 2 minutes.
Appreciate it very much.
Okay.
Thank you.
Okay.
Thank you, Madam Chairwoman and members of the committee. Good afternoon. My name is Robin Yasino. I live with a mental health condition. I'm a mental health advocate with NAMI Montgomery County. I received inpatient treatment, and I know what it's like to be completely rudderless without a treatment plan, completely unacceptable. I did not feel cared for, and I didn't know how I was going to get better. But here's the difference with my case. I was in there voluntarily. My husband was involved with my care. I was able, in a matter of days, to get out and get good care. But too many people, especially those like Shelley's son, who are involuntarily in forensic facilities, they are not involved in their treatment and not allowed to have a representative. While they languish sometimes for years for her son, their members are denied information and they're shut out of decisions. Mental health care is health care. And there are rights that we all have as people who receive health care in any facilities, to have updated treatment plans, to be included in plans for our care, and to involve a trusted loved one when we want to. This makes economic sense. Studies show that including patients and their families in treatment planning while in a mental health facility leads to faster recovery and leads to lower rates of readmission. I know this personally. This is true for my family member who has schizophrenia. Our involvement in his care enabled us to avoid a readmission. Every person who goes into a facility deserves the best possible care and a full life outside of an institution. I urge a favorable report for HB 121.
Thank you.
Good afternoon, Madam Chair, members of the committee. My name is Josh Howe with Compass Government Relations here on behalf of the National Alliance on Mental Illness, Maryland. People with mental illnesses often face challenges to navigating life in these state-run facilities. This underscores the need for appropriate mental health treatment and reassessments. Breakthroughs in science, such as new medication and psychosocial treatment, create a need for individuals to have their treatment plans routinely reassessed. NAMI Maryland believes that House Bill 121 is necessary because, as we can see, there's maybe individuals stuck with ineffective treatment plans and not getting proper reassessments. House Bill 121 would allow for an individual's family or a loved one to be a part of a treatment forming or planning process. And further, the bill would allow for an individual and their appropriate advocates to pursue recourse in order to change the treatment plan to something that may be more effective for that individual. And for these reasons, NAMI Maryland asks for a favorable report on House Bill 121.
Thank you for your testimony today. Are there any questions for this panel? First, we have Delegate Rosenberg.
Statement, I apologize to you and to the committee, but this is a rather detailed statement of what care must be provided. Is there a basis for this in the literature or in practice, whether by statute or by practice in any other state? And should it be applied as well to people who are receiving mental health treatment in a state facility voluntarily, if I may?
Yeah, thank you for the question. They are excellent questions. So part of the bill, there's a couple different sections of the bill. So the first section, I think it's the first section of the bill.
Actually, if I may stop you for a
sorry.
second, I apologize. I have two witnesses that are part of your panel, correct? Let's listen to them, and then we'll come back.
thing.
Delegate Rosenberg, if you can indulge me for a second. We have two virtual witnesses. Mr. Brett Hammond, will you please give us your testimony?
Hi, good afternoon, and thank you to you, Madam Chair, and members of the committee. I'm asking for a favorable review of House Bill 121. My name is Brett Hammond. I'm familiar somewhat with the criminal justice system as a former magistrate in juvenile court for over 4 years, 3 of which I was assigned to a mental health docket, where I listen to prosecutors, defense attorneys, as well as young men and women, and also members of their family in making critical decisions. I'm here today not as a judicial officer, I'm here today as a family member. You heard from my mother earlier today, and you heard some of my youngest brother's story about how, related to the first interaction with the criminal justice system, he now sits in a state hospital. This was a situation where he was at a Staples while my mother was attempting to get medical records to help him out, to get him good medical care and treatment. And an officer stopped him in an attempt to leave the store after he was asked to leave the store. The officer told him he couldn't. He was in fear that he'd be recommitted to a hospital. He had recently been released from one. I just want to try to paint a picture really quickly of why we're here urging support of this bill that's being proposed. I want you to try to imagine a situation where you have a family member or loved one who's suffering from a significant mental health challenge. And related to that mental health challenge, they're charged with their first criminal act. And they're really not able to speak up. They might have a triple diagnosis of anxiety, schizophrenia, and OCD, so they don't feel comfortable speaking to the hospital. But perhaps they speak to you as a family member because they've known you, they know you have their back, and so they provide you with valuable information, but your attempts to provide valuable input to the hospital aren't necessarily welcome. Perhaps you are invited to less than 50% of the meetings. You're not included regularly. And so you have to take extended path of action to show up. I believe this bill would remedy that challenge and that difficulty we face. And so for that reason, I'm urging a favorable review of this bill to help support some of the most challenged in our state of Maryland. Thank you so much.
Thank you. Next, Mr. Brad Hersey from the Office of the Public Defender.
Thank you, Madam Chair. Members of the committee, good afternoon. My name is Brad Hersey. I have almost 20 years of experience as an assistant public defender in our statewide mental health unit. You've heard a lot of good testimony already about this bill. And what I wanted to highlight, and the reason why the Office of the Public Defender urges a favorable report of this bill, is because the provision regarding judicial review by the Office of Administrative Hearings only applies in state psychiatric facilities. I think that's a very important part of this bill. So we're not talking about in all private hospitals. We're talking about judicial review by OAH only in state facilities. And I want to talk about why that's necessary, and I want to be efficient with my time. I want to mention to you in particular that what we're talking about is we're talking about patients in state psychiatric facilities who are asking for additional methods of treatment. That's a big step for them. And if there's a person who's asking for additional methods of treatment, then there's probably something that they really need that they're not getting. I want to share with you a letter that I received just last week. I'm not going to read you the whole letter, but I'm going to read you the most important sentences from that letter. This is from a patient that returned to the hospital voluntarily. He said, it has been 15 months since my return to this hospital for additional treatment. I am still awaiting the substance abuse course, and I have no individual therapy at this time. There is no reason in this state why the department cannot provide those things for that person so that they may be well. And if this bill allows that person to become well and maybe someday come back to the community as a well person, then we have done everything that we could do.
Thank you. So that is the panel, the sponsor panel completely. So we're going to go back to the question by Delegate Rosenberg. Do you recall the question?
I think I do. It
Yes.
was essentially, where do the pieces of the bill come from? Is that fair? So there's a couple different components. One is that if you look on page 2 of the bill, the language regarding the content of treatment plans, the director, which is in MDH, within MDH, is adopting rules and regulations related to the treatment of the plan and the review of the plan. So in this particular case, if it's okay if I mention it, what we found, we went and we found that part of COMAR, and that had not been applied to this family. And so I have reached out to MDH on behalf of the constituent and tried to raise the issue directly, but it also seemed like it was appropriate to at least take what we had in regs, which had been written by experts in psychiatry and put that into the bill. But the thing that I then added beyond that, based on these experiences and conversations with the Public Defender's Office and others, is this is the idea of the family's involvement, and really thinking about and thinking about the way that families are involved, and that there is sort of broader literature that family involvement when someone has a physical condition and they have family advocating for them in a hospital can make a difference. Trying to find a way to incorporate family, and specifically to incorporate family and check in for family at different times. So when someone first goes into the hospital, they may be angry with their family. They may say no, but after they have had a few days and are in a different space, they may actually decide they want their family to participate in their treatment plan. So giving those a couple of options for that. The next thing here is what happens if the family believes one thing is necessarily and the physicians, the treatment team disagrees. That section actually comes out of IEP meetings, where sometimes you have a number of people who are the sort of responsible for the education, the school, who believe one thing is appropriate for the student, and then you have a family member who thinks that's not appropriate, and they discuss it, and if they can't come to agreement, then there is at least a reflection in the treatment plan that there was this disagreement, and here's the reason we didn't go with why the family wanted that. And then the last piece is the section that Brad was mentioning, that is the Office of Administrative Hearings, then appeals to the Circuit Court, that's the set of processes that somebody can go through to appeal whether or not they should stay in a facility against their will. And so in my mind, again, coming back to where I started, if we're holding people in facilities, we should be making sure they're getting the treatment they need. And so if they're there, maybe they're trying to get out, maybe they're not, but they're saying, I need a different treatment plan. Seems like we ought to have, if we're serious about treatment, we would have the same sets of rights. So that set really comes out of those rights that folks have right now in statute to challenge whether they should be staying in an institution against their will. Does that answer your question? Thank you.
I have Delegate Kerr, followed by Delegate Hill.
Thank you, Madam Chair. Delegate Charkoudian, the two letters of opposition, one from the judiciary and the other from Department of Health, both seem to be addressing the same situation. Have you had a chance to take a look at that, and do you have a solution to their concerns?
Yeah, I actually, thank you, only just got to look at them. So the Department, the judiciary is related to this question about the 30 days. Is that correct?
Yes.
I am willing to have a conversation with them. It actually may be an issue. I'm sure that Brad hasn't had a chance to see it since I just got it myself, but it may be an issue that I could work with the Public Defender's Office and see, what the legal structures could be that could address that. Separately, I think it's not here, but the Hospital Association has some amendments they've shared with me that are not, some of which we're still working on them. I just received them recently. I had reached out to them earlier. They had seemed to think it was fine, and then more recently they had some suggestions. So I'm going to keep working with them on it. No, I don't think they are.
Delegate Hill, followed by Delegate Taveras.
Thank you, Madam Chair. Thank you, Delegate Charkoudian. Did you know this is a bear? It's a bear, and I think you're going to win this one. This issue about involving family with patients whose level of understanding and competence fluctuates during the course of admission, right? You're trying to get around that by having them asked up front, do you want your family involved? And then ask again, right? So I guess there's also something called mental health advance directives, right? Where people can fill out in advance. I know that I have a behavioral health issue and I may not make the right decisions. I want you to know if I go in, I want this family member to be involved, even if I say no, right? So I guess what I'm trying to understand, because I think you feel like you've worked it out, and I want to, how does that work like I've, similar situation, we've all, many of us have had friends or constituents who've called to say my kid or my loved one is in there and no one's telling me what's going on. And the hospital has said I can't. And I think sometimes the hospital can, and they just don't because they're too concerned. But can you just explain again that piece? How's that going to work? That the right of the patient to say, I don't want that person involved, and how that changes over time.
Sure. So the part that is addressed in the bill, and thank you for the question and the recognition of how complicated these issues can be, and yet the fact that they're complicated doesn't mean that we should turn away from them. That's just kind of the easy way out, and people are suffering. On the admission of an individual to a facility, so this is on page 3. So it's on the admission, and then it is, that's the first time the question is asked. This is F1. If they consent to any family members or other people, right? It might not be, blood relative, but we have families of different kinds. And then if they agree to participate, then all of these things. And then the individual, so now back to the bottom of page 3, line 28, they can withdraw the consent for that individual. And then at the bottom of that, if they're admitted, wait, sorry, I'm trying to find, there is a place where they get checked in on again, and I'm sorry, I'm not finding it right this second, but there's a place where authorized individuals' right to request. Yeah, sorry, I'll find it and I will email it to you, but.
You can get to the delegate offline, just
Yeah,
to have the answer.
I'll do that. The rest of your question about advanced directive, if the advanced directive, if there's a need to reflect that in here, we could add that. So if you have ideas about like saying that explicitly, that if the advanced directive exists, then that would be respected in this process. We could find a way to do that.
Thank you. Delegate Taveras.
Thank you. Hold on so I could hear you better. Okay, so my question is on this bill. I think that this is a very important bill. The question that I have on it is, in some cases, let's say in the example of the Hammonds, it really was an issue of, let's say, maybe having a police officer not trained in the escalation to address the need, so that this was something that was avoidable. And my concern is, now we have somebody inside that's there needlessly, and now it's costing, right? And so in my experience, because I have had some severe experience with this issue as well, sometimes you are worse off being inside. Where is that option where the person that can opt out of an involuntary internment?
So thanks for that question. And I think I think that is a set of law that this committee has worked on over the years. This body has worked on over the years. And I think that depending on who you talk to, we either have gotten that balance right or we haven't. And there's people who are advocating for a range within that. This bill really isn't getting at that. This bill is sort of saying, given the set of rights that people have to either be hospitalized against their will or not, and whether that's the right place or not, if they're going to be there, then the treatment plans should be making people better. So this bill really doesn't take a position on that question of should people be in a hospital or not, but if they are going to be there, that we're building treatment plans that meet their needs.
And that right now we are even lacking at that.
I would say that it's mixed. I certainly know of people who were hospitalized against their will and came out and were very successful and had a discharge plan and are receiving treatment well in the community. So it's not that it never works right, but it's not in the law, and there's gaps for sure.
I have a question from Delegate Alston.
Thank you, Madam Chair. My question is about the administrative hearing and the judicial involvement. It seems to me it might be faster to just allow them to request an emergency hearing before the court. That could potentially be a workaround of your 30-day issue with the judiciary, because then they would have to rule on it on an expedited basis. So what I'm wondering is, were you trying to give more administrative remedies and more time, or were you trying to expedite the process when a person has an appeal or doesn't agree?
Brad, would it be putting you on the spot to ask you to answer that question?
No, I think I can.
Thank you.
Thank you, Delegate Alston. I think, well, I know that the attempt to bring the Office of Administrative Hearings into this mimics the portion of the law that already exists regarding forced medication. And the reason why OAH is involved in those as well is because, one, they're trained to deal with mental health situations inside state facilities, number one. And number two, it keeps them out of the district and circuit court, out of the county court system. Generally speaking, the amount of appeals that would be involved, even in the cases that I handle regularly on an administrative basis, are very small. So when we're talking now about a subset of a subset. So now we're talking about people who want additional methods of treatment, have gone to the administrative law judge who has denied them an additional method of treatment, and they're still so concrete that they want to appeal that. So I understand the judiciary now has concerns about that. I think OAH really is a way for us to divert things away from the county courts, which are already overburdened, especially since the pandemic. So I think that's why it's in the bill.
Thank you, Madam Chair.
My pleasure. I don't see any other questions. However, I do have one. The Maryland Department of Health wrote a very strong letter of concern. And in the letter, they write, House Bill 121 will have an impact on Maryland Department of Health care facilities. The requirement for clinical staff to reassess a patient's treatment plan and present a full clinical justification will require additional staff to manage these new requirements. Additionally, if upon reassessment, a patient in a state healthcare facility does not agree with a clinical staff review, the individual may file an appeal to the Office of Administrative Hearings. At the hearing, the state will have to justify by clear and convincing evidence that its treatment plan is appropriate rather than the patient or their family, demonstrating why a change in the treatment plan is appropriate. Administrative law judges who oversee these proceedings, these hearings, often do not have a medical background and are tasked with ruling on clinical decisions made by licensed medical professionals. Are you speaking with the Office of the Maryland Health Department?
We have had some conversations with the Department of Health, although not since they have gotten new leadership. But I actually want to ask Brad to speak to that, because the Office of Administrative Hearings regularly makes decisions about medication and forced medication and those kinds of things. So I don't know, can you answer that question about why that's the body, or respond to the concern from MDH?
I think so. If you'll indulge me, Madam Chair, the Office of Administrative Hearings has judges who are specifically assigned to handle dockets regarding involuntary commitment, not just in state facilities, but in private facilities as well. Forced medication hearings, both in private facilities and state hospitals. And additionally, they hear NCR release cases from all the state hospitals. So they routinely make decisions which are within their purview and for which they are accustomed to making. I would also say, I think it's important to note that state hospitals are supposed to be at base having individual treatment plan meetings with each patient every 2 months. So this should not be a process that's foreign to them. And it certainly should not be a process that they are not able to manage in terms of clear and convincing evidence. If they know their business and they're doing what's right, then clear and convincing evidence shouldn't be a problem for them. It's a lower standard, certainly, than beyond a reasonable doubt. So I'm confused as to why that would be such a burden, other than obviously they don't want to have to deal with it. But I think obviously, based on the portion of the letter that I read, they know that they have a problem, which is why they don't want to deal with it.
Thank you. I think that given that letter, I would encourage the primary sponsor to please meet with the Department of Health and try to see if you can come to some agreement. Also, I see that there's an unfavorable from MECI. Have you met with them? All right, if you can also reach out to MECI, that would be wonderful. Any other questions? Seeing none, thank you so much for all of you for coming here today and for giving us your testimony on this very important issue. And this actually will conclude the bill hearing on House Bill 121. Delegate Charkoudian, it was great being with you today, and thank you for your hard work. Next, we have one more bill, and this will be the last bill of the day, and this is House Bill 48, Delegate Bagnall, Maryland Medical Assistance Program, Collaborative Care Model Services, Implementation and Reimbursement Expansion. Delegate Bagnall, will you be so kind and bring your panel to the chair, please? Thank you. And you can get started whenever you're ready. Good afternoon. It's going to go on.
There we go.
Go
Good
ahead.
afternoon, Madam Chair, Madam Vice Chair, members of the committee. For the record, I'm Delegate Heather Bagnall, District 33C, Anne Arundel County, and it is my great honor to be here on behalf of House Bill 48, the Collaborative Care Model Services Implementation and Reimbursement. You have my written testimony, so I will summarize. In our committee, we hear about the mental health crisis and deficit of services nearly every day. And many of us hear from our own constituents asking for greater access to behavioral health care outside of crisis and emergency department settings. At times, it can feel as though we are operating continually in crisis without a means to move into prevention or even management of illness. Maryland has been a leader in this effort, and in 2018, the Maryland General Assembly and this committee created a pilot for the collaborative care model, which creates a care coordination team to provide behavioral health care and resources in primary care settings. In previous briefings, we have had multiple references to the collaborative care model, which integrates physical and behavioral health services in primary care settings with care coordination and management, regular systematic monitoring and treatment, and regular systematic psychiatric caseload reviews and consultation for patients who do not show clinical improvement. It is team-based, patient-centered, measurement-based, evidence-driven, cost-effective, integrated care. In short, we are bringing behavioral health care, management, and prevention to a comfortable setting where patients are most likely to utilize them, addressing the needs of the whole person. House Bill 48 expands on the work of the pilot, which has already yielded impressive results. I've included in my written testimony the interim report, which showed more than 65% of participants demonstrated clinically significant improvement at an annual cost of $775.30 per participant. So why now? Because the need is great, exacerbated by COVID, but created by a national trend of disinvestment in and stigmatization of behavioral health care, a trend which only recently has started to reverse. We have a data-driven, road-tested, fiscally responsible, proven tool already in our tool chest, and House Bill 48 will make it more available to more providers and therefore more Marylanders needing services. Providing services in primary care settings normalizes and destigmatizes treatment for behavioral health disorders, encouraging patients to seek care in their regular primary care clinics, resulting in improved patient outcomes. Before I turn the hearing over to my panel, I wanted to talk about the fiscal note. As we know, robust, comprehensive behavioral health services can be expensive. And the collaborative care model allows us to leverage state dollars for a 60-40 federal to state match, reducing the burden to the state. According to a 2019 report by Healthcare Financial Management Association, preventable emergency department use costs about $8.3 billion annually, And the biggest driver of unnecessary ED use is mental health care. The return on investment in the collaborative care model is about $6 for every dollar spent. It is difficult to reflect the cost savings in a fiscal note, though the HFMA report identified a potential $4.6 billion annual savings. In 2021, Texas passed the collaborative care model, and the Legislative Budget Board in Texas amended their fiscal note to cost neutral, stating, "It is assumed the cost of providing collaborative care management services will be mostly offset by decreased costs related to reduced hospitalizations and utilization of other services." I am not being hyperbolic when I say expansion of the collaborative care model will be a game changer for our state, and more importantly, for our constituents. For these reasons, I am asking for a favorable report on House Bill 48.
Who's next?
I'll go. Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland here in strong support of House Bill 48, which is priority legislation this year for the Maryland Behavioral Health Coalition. We talked about earlier, Maryland has done a great job over the past few years building out its crisis response system, which is greatly needed, and those improvements should continue. But the fact is, nobody wants their first interaction with the behavioral health system to be when they're in crisis. So the coalition has focused its attention this year on targeted community-based reforms that can keep people out of crisis, and this bill, House Bill 48, is a key piece of that strategy. It provides Medicaid recipients with access to the collaborative care model, which, as Delegate Bagnall said, is shown to improve the quality of behavioral health services delivered in primary care settings. See, most people with mild to moderate depression, anxiety, and the like will never see a specialist. Instead, they go to their primary care doctor, but behavioral health services delivered in those settings are typically not the best quality, which results in higher overall costs, poor health outcomes, and increased hospitalization. And the collaborative care model, this model helps. It's a validated, patient-centered approach shown to improve health outcomes and save money. Commercial health insurers in Maryland, Medicare, both of these are already reimbursing providers for delivering the model, and as Delegate Bagnall said, Medicaid has been piloting the model for a few years pursuant to legislation this committee spearheaded in 2018, which is showing really fantastic results. And so it's time to end that pilot, join the 20-plus other states that are providing the service broadly across their Medicaid programs. Maryland Medicaid recipients deserve access to the same proven service already available to those with commercial insurance and on Medicare. And I was going to mention the fiscal notes, but Delegate Bagnall did a wonderful job. Like she said, Texas passed a comprehensive collaborative care reimbursement bill. Again, amending their fiscal note down to 0 after they looked at implementation data from Massachusetts. And if Texas can do it, we can sure do it too. So I'll stop there and say thank you for your support.
I don't know that that helps you here, but no. Who's next?
So my name is Verna Little. I'm a psychologist and a social worker, and I've been a collaborative care manager for over 20 years. I've done hundreds of implementations around the country, including here in Maryland. And so I really wanted to just give you an overview of what collaborative care is. It's an evidence-based model that identifies and treats patients with depression and anxiety alongside their trusted primary care provider. And as we know, most prescriptions for medications for depression and anxiety are actually written by primary care providers. Many people who die by suicide saw their primary care provider in the month of death, and more than half of individuals get their mental health care from their primary care provider. So it's incredibly important to bring this care into primary care. Collaborative care brings two people directly onto the primary care team. The first is a care manager. This is a behavioral health professional who really works closely with the patient, measuring their symptoms, talking about their symptoms, setting goals, and essentially following them using two tools to measure depression and anxiety symptoms, looking for a significant reduction in those symptoms, changing their daily experience, often within a matter of months. A registry is used to really care for all patients in the practice so that no one falls off the radar and anyone with depression or anxiety has a care plan. The second person brought directly onto the care team is a psychiatric consultant. This person meets with that care manager, talks about patients who aren't getting better, who are getting worse, and makes recommendations to the care manager around treatment and to that primary care provider around medications, treatments, and labs. And this allows patients to get better. So I strongly encourage your support. Thank you.
Okay.
Yes.
Thank you for the opportunity to present here. My name is Henry Harbin. I'm a psychiatrist. I live in Baltimore City. I've been involved in trying to make improvements in mental health and substance abuse care for over 4 decades, both here in Maryland and nationally. I'm here representing a national coalition of large employers as well as mental health organizations called the Path Forward for Mental Health and Substance Use. We've been encouraging the implementation of collaborative care nationally as well as in Maryland now for about 3 years, and are pleased to see the growth of this. I really just wanted to make 2 kind of points about the importance of this intervention and what it would do for our citizens in Maryland. The first is that many of you may know, we have a lot of research that shows the lag time between somebody who has a symptom for a mental health problem or substance use before they get diagnosed and treated is 10 years. You imagine if the President of the United States was presenting to Congress during the COVID crisis and said, well, I want to give you an update. From the time you get a fever and a cough, it'll be about a decade before we diagnose and treat you. I think that person might be impeached, no matter what party they were in, pretty quickly. That's the situation in mental health and substance abuse today. The screening and early detection of these illnesses can only occur in the general medical system in primary care by pediatricians, et cetera. That's where mostly all other medical diseases are detected, whether diabetes, blindness, hearing, et cetera. So this bill would give the resources to these primary care clinicians to be able to screen and track these individuals so they can be treated in less than 10 years. The other point is that the other important part about this is that we are in a mental health substance abuse crisis. The death rates from suicide and substance abuse for the last 15 years are continuing to escalate. A lot of money has gone into mental health and substance abuse, particularly in the last few years, not enough, but very little of that money has gone to primary care doctors and clinicians who are the ones who are treating the majority of these people. Thank you very much.
Who's next? Good afternoon.
Good afternoon, everyone. My name is John Miller. I am Executive Director of the Mid-Atlantic Business Group on Health. We are a coalition of corporations, and we are the local implementation arm, you might say, of the national program that Henry referred to a moment ago. Some of my members are T. Rowe Price, Marriott, McCormick Spice Company, others, most of them, almost all of them headquartered in Maryland. What we are trying to do is help those organizations provide the highest possible quality health care in a cost-effective manner, and we strongly believe that the collaborative care model is completely aligned with that wish. My members are represented by human resource folks. So the person at Marriott who arranges health services for the employees and dependents and retirees at Marriott is a member of our organization, as is usually the case with the corporations that are members of ours. Those folks are very well acquainted with the mental health crisis that we're all referring to, in the fact that employees come to their offices frequently, and although they have mental health coverage, they are not able to find support that they need, their spouses need, their sons or daughters need, and so they come to this human resource person in search of help, and it's quite an anguishing situation for the person in HR who really just doesn't know what to say. The collaborative care model will alleviate, won't solve, won't cure, but will alleviate that issue because it helps primary care providers provide much better behavioral health support. It's no knock on primary care providers that they don't receive extensive training in behavioral health conditions. That's what the specialists do, but this provides them with support that helps them improve the support they offer their patients immeasurably. So our main concern really is this human aspect because it keeps my members awake at night. Additionally, though, we are an employers coalition. I would be remiss if I didn't point out that there are significant savings to be had, and we also appreciate those savings that can be had from the collaborative care model. For both of those reasons, we are urging a favorable report on this bill. Thank you.
Thank you. We have someone on your panel, Pam Casemeyer.
Hello, Madam Chair, members of the committee. Pam Casemeyer. I'm here actually on behalf of the State Medical Society, the Mid-Atlantic Association of Community Health Centers, the Clinical Social Work Society, and also the Academy of Pediatrics is weighing in now as well, all in support. I'll save you a lot of time. You've heard great testimony here. I think what I would say from the side of the medical community, many of our clients are the primary care provider side of things. You guys, for a long time, the legislature and policymakers have focused on building up the whole concept of the medical home and comprehensive care and one place to go. And this wraps into it the behavioral health side of things, which has become a continually emerging and more significant problem. So with that, I'll say me too and give you back a minute and hope that we can move forward with this legislation.
Thank you, and thank you all for your testimony today. So are there any questions for this panel? We have Delegate Hutchinson, and then Delegate Rosenberg, and then Delegate Shaliga.
Thank you, Madam Chair. My question is actually for the gentleman from the Business Coalition. At the tail end of your 2 minutes, you started talking about savings, and if you could just elaborate on that more, please.
Yeah, we are aware of a Milliman study of 21 million patients that looked at claims. That Milliman study discovered that patients with behavioral health conditions cost 2 to 5 times more than those without those conditions. And interestingly, those costs are not because of the additional cost of treating the behavioral health. They're actually reflected on the medical side with folks who are suffering from behavioral health issues. Sure.
Delegate Rosenberg.
Well, mine is more of a comment than a question, but Dr. Harbin, I believe the last time I saw you, it was at a budget hearing for the Mental Health Administration.
Many years ago.
When you were the director, and I was a member of the Budget Health Subcommittee. How does this bill fit into the progress that we've made since that 20-plus years ago?
This bill, as I mentioned, there's been a lot of improvements in the delivery of specialty mental health programs, both for the seriously mentally ill as well as people with mild or moderate. But there hasn't been a consistent support for primary care doctors to do a better job. They are, as said earlier, they prescribe most of the psychiatric medications. A lot of the people with mild and moderate illnesses do have much higher medical costs. If you have depression and diabetes, you cost 3 to 5 times more than a person with just diabetes. So the evidence is overwhelming, Delegate Rosenberg, on the impact of this. And I think this would, because this is so proven. One point I'd like to add is right now, a lot of the big medical systems in Baltimore and also in Prince George's County would like to start billing for all patients. Medicare pays for this, all the commercials pay, but they don't want to start billing if 60 to 70% of their money comes from Medicaid. So they're holding off really moving this forward on behalf of all of their patients.
Delegate Shaliga.
Thank you, Madam Chair.
My pleasure.
So 2 questions. The first one's quick. I remember this bill, Delegate Bagnall. Was it from last year with the pilot program or the year before?
The pilot program was from 2018, but this expansion was part of a larger omnibus bill last year.
So it's been piloted at 3 sites, or was that expanded?
3 sites.
And
So their previous sites, I'm not sure, I think they're in, I'm not sure exactly where those sites are located, but we can get that information to you, Delegate Shaliga.
it ties into the fiscal note that talks about the Department of Health recommending that we continue the pilot program until the end of 2023, because that's when the report would be due, so that we could really get a full assessment, and that they're concerned because of the impact that COVID would have had on it. So Delegate Bagnall, I just ask you to address the middle paragraph on the fiscal note and their recommendations. And I did not see the Joint Chairman's report, but maybe that would be a helpful thing for the committee to look at.
If I may, Madam Chair?
Yes.
The sites are Waldorf, that was the rural site. The urban sites were Frederick and Silver Spring. And the report should have been in the written testimony, as well as there's a link on the bottom of the department, which also shares the same interim report.
And actually, the question that Delegate Szeliga had was a question if you see me talk to council, I was going to ask. The Department of Health seems to imply that it would be good to wait, right, to the end of 2023 to fully assess, its impact, although the letter from them was very positive, to fully assess the impact and the cost, especially given that a lot of that happened during COVID. So my question to you will be, why not wait to the end of the year?
It's twofold, why I think it's reasonable to look at this now. One, I think the report, though it will give us more information, it's still going to have the COVID impact. So the report will give us the ability to compare, I guess, COVID and then as we expanded beyond COVID. But two, it's the need. The need has become great. This is a tool that we already have data that it is meaningful and impactful. And three, sorry, I said two, but it's three, is that it takes time to build up this expansion. It's not something where we can flip a switch and automatically we're statewide. It took from 2018 to 2020 to set up the pilot. So even the fiscal note is reflective of if every primary care facility utilized this, and I think it's 65% of eligible participants participated, that would be the fiscal note. So I think it's reasonable to start the expansion knowing that it's not going to be an overnight effort.
Yeah, and the report for the committee members, the report there is in the file and is very positive. And the letter says that we will get $12.8 million from federal matching funds as well. Any other questions? Thank you very much for your testimony today. We really appreciate it. Next, we have a favorable report from the Maryland Coalition of Families. And Gittes. Hi, how are you?
Good afternoon,
Good afternoon.
Madam Chair and committee members. Thank you. My name is Ann Geddes. I'm the Director of Public Policy with the Maryland Coalition of Families. MCF provides family peer support and navigation services to families who care for a child, youth, or adult with behavioral health needs. And I'm here in support of House Bill 48. Specifically, I want to address the positive impact that House Bill 48 would have on children and youth who are enrolled in Medicaid and their families. Mental health disorders affect 1 of every 4 or 5 children and adolescents, but fewer than 1/2 with a diagnosed mental health disorder receive treatment. This is partially due to the tremendous shortage of child and adolescent psychiatrists. Currently, there are some 7,000 practicing psychiatrists in the United States, and it is estimated that the nation requires 30,000 to adequately meet the needs of children and adolescents. It's also due to the stigma that surrounds seeking out specialty mental health services. For these reasons, children and adolescents who do receive mental health services are usually cared for in primary care settings. More than 1/2 of pediatric primary care visits address mental health problems, and pediatricians write 85% of psychotropic medication prescriptions for youth. As things currently exist, this is not always ideal. Pediatric mental health conditions are frequently difficult to diagnose. They commonly co-occur with learning or developmental delays, which can be difficult to untangle. Prescribed treatment is not always effective. Pediatricians report challenges to providing quality mental health care, including lack of mental health training, insufficient time to adequately address all needs, lack of knowledge about community resources, and inadequate reimbursement. The collaborative care model, which has been proven, as has been said, to be effective in improving outcomes in numerous studies across the nation, addresses all of these issues. By teaming a pediatrician with mental health specialists and closely measuring progress, mental health care in primary care settings dramatically improves. As has already been said, Medicare and most private insurance already reimburse for the collaborative care model, and it's time that Medicaid do the same. I just want to add quickly that there have been a number of articles recently in the press about kids who are in mental health crisis who are languishing in emergency departments or stuck in inpatient units in hospitals waiting for a residential treatment bed. It's only by providing quality interventions upstream that we can begin to avert this suffering and cost. The collaborative care model would help to divert some of these children from these higher levels of care. Therefore, we urge a favorable report on House Bill 48.
Thank you. Are there any questions? Yes, Delegate Kerr.
Thank you, Madam Chair. Ms. Geddes, I just have a question about your data point that said 70% of health prescriptions for youth are written by pediatricians.
85% was the data I found in a study, yes.
Is that depression and anxiety, or are you also including Adderall for ADHD?
It would also include ADHD.
Delegate Hill, are you all right? Delegate Hill?
Yeah, thank you. You may not be able, but I think you can answer this question. I think this is a good bill. We're going the right direction. But I also understand that one of the problems we're facing is that with more and more behavioral health, initial diagnosis and treatments being handled at the primary care level, we're also seeing more and more people who are being misdiagnosed, misprescribed, and mistreated. And I'm wondering if that is your experience, and if so, is there something we should do, perhaps through this bill, to also make sure that folks receiving care for a period of time actually are referred to psychiatrists to confirm that they're getting the right treatment and the right diagnosis?
Yes, that's precisely what the collaborative care model would do. I mean, along with psychiatric consultation, there's measurement of progress. If there is no progress, if there seems to be a misdiagnosis or treatment isn't working, then there's referrals made to specialty psychiatric care.
I think it's from the psychologist that be moved out, that the model not focus so much on psychiatric support, but that other providers be allowed to substitute for that. Would you be in favor of an amendment that would decrease the role of psychiatrists in the model?
So I'm not aware of the amendment, but I think the model as it exists has again been implemented in 20 states, been implemented by Medicare and private insurance, and I think the model that's been evaluated stands on its own merits. So, but yeah, I haven't seen the amendment, so I couldn't say.
Thank you. Any other questions from the committee? Seeing none, thank you very much.
Thank you.
May I please have Lead Hudson and Kristen Pendergrass? Thank you. Good afternoon.
Good afternoon. Thank you, Madam Chair, members of the committee. My name is Kristen Pendergrass. I'm Vice President of State Policy for Shatterproof. Shatterproof is a national nonprofit dedicated to ending the addiction crisis across the country. We have three main priorities. The first is educating and empowering our communities. The second is addressing stigma. And finally, increasing access to quality addiction treatment, including the collaborative care model. I'm going to try not to repeat what everyone else has said, how the collaborative care model works, but just want to point out that it is also effective for people with substance use disorder. One study found that the collaborative care model for opioid and alcohol use disorder increased both the proportion of patients receiving evidence-based treatment and the number achieving abstinence from opioids and alcohol at 6 months. The collaborative care model equips primary care providers with tools to identify and address substance use disorder early and measure treatment progress. For opioid use disorder specifically, a primary care provider may not feel comfortable prescribing medications for opioid use disorder, which are the gold standard for treating opioid use disorder. One of these medications, buprenorphine, can now be prescribed by any provider with a license to prescribe controlled substances, and the collaborative care model gives primary care providers access to a specialist with expertise to provide consultation and support. You've heard that in addition to the health benefits, collaborative care is cost-effective. Many studies have shown a reduction in overall healthcare costs and a return on investment of approximately $6.50 to every $1 invested, and this is largely due to reductions in acute care like emergency department visits. The collaborative care model has shown reductions in disparities based on race, ethnicity, and socioeconomic status. There's also evidence to suggest that the model leverages psychiatrist time over 3.5 times, which is crucial given the current behavioral health provider shortage. And to date, 22 states provide Medicaid coverage for the collaborative care model. Thank you.
Yes.
Good afternoon, Madam Chair, members of the committee. Thank you for receiving my testimony. I'm Lee Hudson from the Evangelical Lutheran Church in America. I'm here to say me too on House Bill 48, primarily because in our advocacy for access to appropriate and adequate health care, we do include emotional and behavioral health. And so we say me too because this bill promises an expansion of access to health care for a group of people who are already qualified for assistance with their medical care. Thank you.
Thank you for being with us today. Are there any questions from the committee? Seeing none, I do have a question. Are you related to our former chair, Pendergrass?
No, I'm not.
Okay.
I'm from Oregon.
She would ask, so I'm asking for her. Thank you for being with us.
Thank you.
Next, we have Deborah Brocado, an unfavorable testimony. Good afternoon again.
Good afternoon again.
You can get started.
Again, I'm Deborah Brocado from Maryland Right to Life. We do appreciate the goals of the collaborative care model to treat mental health, but we do oppose the abortion funding that would be in this bill. In this collaborative care model from February 2022, we see that the current pilot awardee is Privia Medical Services. They provide collaborative care services across 3 focus areas, 5 in urban, they consider urban, Silver Spring and Frederick, rural, 2 sites, Salisbury and Waldorf. But the ones we're concerned about are the 5 sites that are OBGYN in Rockville, Towson, and Silver Spring. We do know that the Department of Health includes the risk to mother's current or future somatic health or risk to the mother's current or future mental health as a reason that abortion may be covered through medical assistance. And then when we look at the chairman's report on the collaborative care services, we see that Privia obstetric gynecology practice expected to enroll a population of 45 pregnant and postpartum individuals into their collaborative care services per year who screen positive for depression. Abortion is not healthcare, it's not mental health care. Abortion is not treatment for depression. It's not treatment for anxiety. It's certainly not treatment for schizophrenia. I do appreciate wanting to treat mentally ill people. I definitely have members of my family who have suffered with mental illness. Also, in my experience of over 8 years at a crisis pregnancy center, working with clients who were currently pregnant but had experienced pregnancy or an abortion from a prior pregnancy, they suffered mental illness as a result of the abortion. It caused them to be depressed. They also experienced suicidal ideation. So abortion certainly caused their mental illness, and it did not help it. It is not helpful to tell a woman who is suffering with mental illness that killing her baby is a way to treat it. So we do ask that you provide exclusionary language that prohibits abortion funding in this bill. Thank you for your time.
Are there any questions for this witness? Seeing none, thank you for your time and for being with us today. Next, we have Sarah Frizzell, and it's a virtual witness. If you'll be so kind and just wait a second for staff to get her on. Will you be so kind and unmute yourself? Thank you. How are you?
Hi, good. Can you hear me okay?
Yes, we do. You can
All right,
get
great.
started.
Okay, thank you. Hi, everyone. My name is Sarah Frizzell, and I'm a licensed clinical social worker in the state of Maryland, and I direct a collaborative care program in Montgomery County. We've been operating since 2005 as the Montgomery Cares Behavioral Health Program, and we've had such a great support and strong response in the community that we're very excited and encouraged to see the expansion in Maryland. I've been both a provider in the program as well as overseeing it. I've had great conversations with both providers who are so grateful to have on-site support when they encounter someone with depression, anxiety, or intimate partner violence, or heard from patients who said they're also grateful to not have to navigate complicated behavioral health systems on their own. In fact, when I go to my own primary care office and explain what I do, often my provider is very jealous that they don't have the same thing there. Our experience is that with our program, about 2/3 of our time is spent on non-traditionally billable codes. Luckily, we are funded by the county, but we can see the benefits of Medicaid expanding this program. So in conclusion, myself and the Primary Care Coalition really support the expansion of collaborative care in Maryland. Thank you.
For this witness? See none, thank you so much for being with us this afternoon. We really appreciate you and those of you that came. This actually concludes the bill hearing on House Bill 48 for the committee. If you could stay just 1 second, please. You have a blessed evening, everyone. So for the committee, I want to thank you for your time. I think we're doing pretty well on time. I've been trying, if you see me that I'm a little strict on the questioning, it's because I want to get you out of here. We do have access to these witnesses, and a lot of these bills will be assigned to subcommittee, okay? For your scheduling purposes, so you can plan ahead, on Thursday, we will be having our